Good afternoon, everybody. This session with Dr. Zafereo is medullary thyroid cancer considerations before, during, and after surgery. Dr. Zafereo is a head and neck surgeon and tenured professor at the University of Texas MD Anderson Cancer Center in Houston. He is a section chief of head and neck endocrine surgery and associate medical director of the Head and Neck Center. He has served on the board of directors of the International Thyroid Oncology Group, ITOG, and the American Academy of Otolaryngology, Head and Neck Surgery, and was recently elected to serve on the board of directors of the American Thyroid Association. His clinical practice focuses on patients with thyroid cancer, particularly patients with advanced thyroid cancer, wherein he leads several multi-center neoadjuvant phase 2 clinical trials. Dr. Zafereo is a ThyCa medical advisor, and we thank him for that. Well, hey, happy to welcome Dr. Zafereo.
Well, that was much too kind of an introduction. It's always a pleasure to be here with you all at ThyCa. This is, I think, about my 10th year in a row to speak at ThyCa on medullary thyroid cancer. And so some of you, obviously I've met many of you before. Some of you have been my patients. Obviously, we see a lot of medullary thyroid cancer, and medullary thyroid cancer patients have a special place in our heart. So we always look forward to answering questions, so we certainly will have plenty of time to do that. Feel free. I have two talks. This first one is some general principles about medullary thyroid cancer, including surgery and adjuvant therapy. And then we have some updates on some clinical trials in the second talk, including a new trial we're just started at MD Anderson, and one trial we just finished that we just presented at ATA, American Thyroid Association meeting a few weeks ago.
Great. Thank you.
Okay, well, we'll get started. So this is our multidisciplinary team at MD Anderson. It does, as you all know well, it takes a whole multidisciplinary team, surgeons, endocrinologists, oncologists, radiologists, everybody, genetics, to treat patients with medullary thyroid cancer. So, and just to disclose, I do have clinical trial research funding from Eli Lilly, Merck, and Exelixis. The Eli Lilly trial is directly related to medullary thyroid cancer because it's with a RET-specific inhibitor. I'll talk about that trial in the second talk. And then Exelixis trial is also going to include medullary thyroid cancer patients. So these two are directly related to some of the things we'll be talking about. The Merck trial is related to anaplastic thyroid cancer. So I think for most of you, this is review, and you know this, so I'm not going to spend much time on it. But for a long time, and these are the guidelines that were published in 2015. So I'm actually on the new guideline task force, which is chaired, of course, I think you all heard from Mimi Hu already. So we're working on a new set of guidelines, which should be released definitely before the next ThyCa meeting. Whether it'll be in 2025 or early 2026, I would guess probably early 2026. So there will be some updates to guidelines. These are the old guidelines. And it's been sort of agreed upon for a long time that patients with medullary thyroid cancer get a total thyroidectomy and removal of the central compartment lymph nodes. Those central compartment lymph nodes are the lymph nodes that are in level 6. We call it level 6. That are the lymph nodes right around the thyroid gland. So those lymph nodes, there's some in the midline, over the trachea, some on the right, some on the left. But those are all kind of right around the thyroid gland there in level 6. And if you're looking at anatomically, the boundaries of that are what are called your carotid arteries, which are these big arteries that go from your heart to your brain that are in your neck. So that's the standard surgery. Although I think it's important to recognize that there's a lot of de-escalation within thyroid cancer and thyroid surgery in general, and most of this de-escalation is for rather more indolent papillary cancers is because that makes up, you all probably know, about 85% of thyroid cancer, medullary being a smaller, less than 5% of thyroid cancer. So there's a lot of de-escalation going on in papillary thyroid cancer, and some of that has spilled over into medullary thyroid cancer, sort of the recognition that we don't have to do the maximal surgery, total thyroidectomy and central compartment nodal dissection on every single patient. There is, I was actually honored to give to be one of the keynote speakers at the Japanese conference. So this professor, Dr. Miyauchi, invited me to give a talk in Japan a few months ago. So I was just there in Japan with him, and they've really led the way in describing some of these studies. This study was actually published 25 years ago, so it's been published for a long time. But I think this is also it was published 10 years ago, 2014. But this is a study of unilateral surgery for RET germline negative patients. So those patients, these are patients with sporadic medullary thyroid carcinoma, so they don't have the hereditary type, and doing what we call unilateral surgery in these patients. And so I think that is a very reasonable strategy for patients who have sporadic medullary, non-hereditary medullary thyroid carcinoma and don't present with advanced disease. Now, of course, many of you here probably presented with disease which was a little bit more advanced, and this may not have been an option for you. But I think for some patients who are presenting with a little bit smaller burden disease, I think this will continue to be something that is looked at. We've started to do it for quite a few of our patients with, again, only sporadic, because we all recognize that the germline patients, so we know the germline patients make up about 25% of medullary thyroid carcinoma patients. Those are the patients with the hereditary RET mutations. Those patients have the RET mutation susceptibility gene in every cell of their body, and so, which includes every cell of the thyroid, right? So then you would think that if one of those patients is having a surgery and they've got the germline, the hereditary type, and they have a tumor on one side, although they may not have a tumor on the other side, those cells on the other side are also at risk. And so that's why we typically, in those cases, would take out the whole thyroid. But if you have sporadic, it just means that you just had a rogue cell within the thyroid. It's not in every cell of your body. It's just a rogue cell in the thyroid that had this mutation. It's not in every cell of the thyroid. It's only in those cells that have the tumor. And so if you take out half the gland and there's nothing on the other side, then you can potentially get rid of the entirety of the cancer that way in some patients. So I think this is something that we're continuing to look at, and some of our patients are having unilateral surgery if they have if they present with sporadic medullary thyroid cancer. So, and this was, so I think this is a recommendation from the 2015 guidelines. I think there will be some, I'm not sure that it'll be in this coming guidelines, because the guidelines that will be, the new guidelines that will be published, I think you all may be aware, and in late 2025, early 26, are mostly going to be focused on systemic therapy and not so much on patients with early stage disease. So it may not, this recommendation may not change in the new guidelines, but would just say that this is another example. This was a prospective trial of unilateral surgery for non-hereditary medullary thyroid carcinoma in patients without germline RET mutations. Again, in the World Journal of Surgery, showing some good long-term data in this patient population. So I think to answer this question, can we be more selective for early stage disease? I think that we definitely can. And so this is looking at the SEER database. These are two different studies. This one both published in 2022. looking at patients from 2000 to 2018, and this was looking at patients from 2000 to 2015. And excuse me. So if we're looking at both of these studies looked at total thyroidectomy versus thyroid lobectomy. So basically taking out the whole gland versus taking out just half the gland. And you really don't see these curves are kind of overlapping here. You don't really see much difference. And so I think, even these sort of SEER studies, retrospective studies show that it is reasonable to consider lobectomy in patients with sporadic non-hereditary medullary thyroid carcinoma. So I'm going to skip over this slide, but it's basically showing the same thing. No difference in patients who had a lobectomy versus a total thyroidectomy. This is looking at it, according to age, whether or not they're under 60 or greater than or equal to 60. So so in answer to this question, yes, I think we can be more selective for early unilateral disease. You may achieve a cure with unilateral surgery for patients who present with early stage disease. And for patients who have late stage disease, I think, this is another consideration, specifically looking at these patients who are present with disease over 60. So one of the things that one of the principles of thyroid surgery that differs between papillary cancer and medullary is that with papillary cancer, and you all who are medullary thyroid carcinoma patients may not be as aware of this, but for papillary thyroid carcinoma, when patients present with advanced disease, there's often a sentiment that you want to take out the whole thyroid because you want to give them radioactive iodine. Well, we know that radioactive iodine doesn't really help for medullary thyroid carcinoma, so we don't use it. And so there's not that reason for patients. Let's say somebody presents with a medullary thyroid carcinoma in their thyroid gland, and they've got some distant metastasis to their lungs or their bone or their liver at presentation, which is fairly common. Some of you may be in that category. Well, I think there's not a sentiment that you need to take out the whole thyroid gland from the sense of needing to give patients any adjuvant therapy, because we're not going to be giving radioactive iodine. So, if that patient were to need systemic therapy down the road, let's say they were to need a drug, whether it be, cabozantinib or vandetanib, one of the traditional drugs or one of the RET specific inhibitors, or maybe some of the new drugs we may talk about later. But if they're to need that drug, it's not gonna matter whether they had a total thyroidectomy or a lobectomy, as far as giving that treatment for the systemic disease. So I think even for patients who have late stage disease, as long as the local disease is limited to one side, I don't think you need to take out the whole thyroid gland. And I think that's something that will become more and more sort of common, something that we're already kind of doing at MD Anderson, and I think it's something that will become more and more common around the country over the coming years. So, and then we look at we look at the lateral neck. So I have a couple of slides here. This is just review. I think some of you have seen these slides before, but so this is the midline, the central compartment, level 6. But then you start to get to the lateral neck out here. You have a lateral neck on the right, on the left. And when you look at the lateral neck, this is looking at this patient's left lateral neck, right? The midline is over here. This is their left side. There's their ear right there. And this is the lymph nodes that are further away from the thyroid levels 2, 3, 4, 5. So these are different levels of the neck. And I think, again, historically, there was a lot more aggressive surgery in terms of doing lateral neck surgery at presentation for basically most patients with medullary thyroid cancer. I think that was the norm. Well, it was the norm for treating most patients with medullary thyroid cancer, got a lateral neck dissection at presentation. And I think that's definitely changed over the last 10 years. We're much more selective about when we do this surgery. certainly, patients who have disease in those lymph nodes at presentation, we do an ultrasound, we do a CT scan to look, and if we see lymph nodes that are involved on either lateral neck, we're going to recommend a lateral neck surgery to remove those lymph nodes. That's kind of intuitive, common sense that we would do that. But I think that the real question is what if you don't have disease in those lymph nodes? We know that these lymph nodes are at risk with medullary thyroid carcinoma, but we're no longer doing these surgeries, kind of a lateral neck surgeries electively. That's our practice, but it's not. I have to say that's not a completely uniform practice. I think that's probably the most common practice in the United States is not to do elective lateral neck dissection, but there's still some in the United States who recommend it. And in other countries, it's also varies a bit. So I think you will see some differences in that. And so when we look at risk of lateral neck disease, we're always looking, again, we're comparing it to papillary thyroid carcinoma, PTC, and looking at medullary thyroid carcinoma. About 60% of patients with medullary thyroid carcinoma have central neck disease. About 35% present with lateral neck disease, and about 30%, or maybe a little bit more than that, present with distant disease. So the lateral neck risk is a lot higher than what we see in papillary cancer, but it's still not most patients. And we also recognize that if patients do have microscopic disease in the lateral neck and it does present years down the road, we can always go back and do that lateral neck surgery. So we're not burning any bridges there in terms of if we don't do the lateral neck surgery up front. So there's been the American Thyroid Association guidelines have commented on this and other guidelines over the years, and it's often been quoted. One of the studies that's been quoted is looking at some German data and looking at calcitonin levels to guide whether or not you do that elective dissection. And this is some of that data. This is a German surgeon, Mackens, published this in 2010, and looking at kind of looking at these calcitonin levels and what they mean in terms of lateral neck disease and also distant disease, right? So and these numbers are still fairly valid in terms of sort of predicting when you may start to see lymph node metastasis. When you're looking at calcitonins that are between 20 and 200, for example, these three rows here, and this blue box is circled here. You see, 10% here in the ipsilateral lateral neck, and up to 20% when it gets up between 100 and 200. So you start to see those lateral neck metastasis in a minority of patients when you have calcitonins that are 50, 70, 100, 150. It's often that's when you start to see it in the lateral neck. When you start to get between 200 and 500, you can start to see it in the contralateral lateral neck, the opposite side from the primary tumor. And then when you start to see over 500, that's when you start to see some of the distant disease. So, in your clinicians who are seeing patients with medullary, they often kind of use these numbers as kind of a general gauge. When do we start worrying about distant metastasis in a patient, with newly diagnosed medullary thyroid cancer? It's not a perfect science, but when you get that calcitonin over 500, that's kind of when you start to worry that there could be distant metastasis. And so this is some of the data that some of the earlier thought was based upon, when you think about using calcitonin levels as a guide for when to do the lateral neck surgery if there's nothing there grossly in the neck. And so it's been about 8 years ago now, we published this study that looked at we felt like that we were over treating patients. We were doing too much lateral neck surgery on patients. And so we looked at the morbidity of these surgeries and also what happens to patients whose lateral neck compartments are observed. This was a study from 2017. This was actually published from Toronto. This is the largest center in Canada in terms of thyroid cancer, and looked at bilateral lateral neck dissections for thyroid cancer. This is not just medullary thyroid cancer. This is any thyroid cancer. And, there's a fair degree of morbidity from those dissections. This was only 60 patients, but fair degree of morbidity. Some of you who've had these lateral neck dissections, most of the time, it goes well. There's not major complications, but when you start doing it on both sides, which was historically recommended for calcitonins over 200, which is a lot of patients. You start to see more morbidity and complications. And so we kind of looked at what happens when we don't do that. And we found similar biochemical cures, local regional disease status, and distant metastasis and survival. So when patients have a negative ultrasound and CT in the lateral neck, we don't dissect that neck electively. And that's because we have to balance, these factors. We didn't see any difference in these kind of things that we look at in terms of survival and biochemical cure, but you do see some difference in morbidity if you're doing that electively all the time. So
I'm sorry for the ones. I'm new to this. So
oh yeah,
when
welcome.
you talk about low stage, are you just talking, I don't know, low stage or high stage?
Well, it's not, I think there's certainly a staging system for medullary thyroid cancer, which is stage 1, 2, 3, and 4. So, when we're talking about early stage disease, you're typically talking about stage 1 and 2. But I think, this conversation that we're having about doing unilateral surgery is where the context came, where this was being used in terms of early stage. And I think it's not just the early stage patients. It's also we're also doing a unilateral approach for late stage patients too. It just depends on if they have anything on the other side. If all of their disease is limited to the thyroid and the central compartment lymph nodes on one side, or even the lateral neck nodes, we'll often do unilateral surgery for and that's in 2025 for non-hereditary patients. But I don't know if that answers your question. Are you just asking in general about the staging system, or?
Well, it seems so. Everybody I talk to has a stage 4.
I know.
Now,
Yeah,
how
I
do
know.
I know?
That is true. That is true. So I have to say the staging system for medullary thyroid carcinoma is not that good in terms of really prognosticating. It's something that I think eventually we'll probably have a different staging system, but it's not particularly good. Like you said, there's a huge group of patients who are in stage 4 because anybody with distant metastasis has stage 4. So, that's anybody with distant disease has a stage 4, and there's a significant variation within stage 4 of like how patients are doing and their prognosis, and that's based on like things like calcitonin doubling time, based on looking at various calcitonin doubling time is probably our best sort of prognostic marker that's commonly used, but that's not included in the staging system, so it's not included at all. So, the staging system, stage 1 and 2 are basically small tumors with very limited neck disease. Stage 3 is a little bit bigger tumors with, more lateral neck disease. And then stage 4 is you've got distant disease, but it's not terribly helpful because, we still have many stage 4 patients who do very well for many, many years. And whereas in, some other cancers, if you've got stage 4, your prognosis is much more guarded, so it's not like that. There's a huge array of prognosis and sort of good prognosis and not so good prognosis within stage 4, which is not the same as in other cancer types. So yeah, and I think the other thing probably to mention is oftentimes, you said that everybody you talk to has stage 4. Well, that's because a lot of medullary thyroid cancer patients have stage 4. That's one reason. But the other reason, just to be honest, is probably because patients who tend to come to conferences, patients who tend to be active within the medullary thyroid cancer community, usually, not always, but usually they tend to be the more advanced disease patients, because the patients who have early disease and are cured with their surgery, they're just not as invested in it. It's just, I think that would make sense. They're not. In fact, if we took a poll around the room here and looked at, and I have not done this, but how many patients in this room have stage 4 versus stage 1, 2, and 3, it's going to be a lot different than if we took, just a random sample of all patients who had medullary thyroid cancer. So that's probably some of that reason too. But the staging system is not great, and it's not a very good prognostic marker for medullary thyroid cancer. Does that answer it?
I'm going to go to Elliot. 21 years, stage 4.
Yeah, exactly. So there's stage 4, 21 years. So that's exactly, that's what we're talking about. So that's, we've got a lot of patients in that stage 4 category who live for decades and are doing fine. So now that's not to say that every patient's like that. I mean, we have to be realistic. It's not that way for everybody, but we do have that for a lot of patients.
Hi, I have 2 questions. The first one I think is pretty simple, and the second one less so. When you're doing a lobectomy, do you take any lymph nodes? Do you clean out part of the central neck? Or?
Yeah, you're going to want to. You're going to want to do that for medullary thyroid carcinoma, because, I mean, going back to this slide, I mean, the rate of central compartment lymph node metastasis is like over 50%. So it's very common to have lymph node metastasis in the central compartment. So if you're already there, right, and the thyroid, the lymph nodes are literally like millimeters away from the thyroid gland, centimeters away, centimeters to millimeters. I mean, you're going to want to clean out everything on that side just because you're right there. There's not a lot of additional morbidity with doing central compartment dissection surgery when you're already doing a thyroid lobectomy. So you're going to want to do that central compartment dissection on the side that you take out the lobe, definitely. It's just a matter of if you venture to the other side, because that has, most of you in this room probably have had your whole thyroid removed, and that's fine. I mean, patients do great with having their whole thyroid removed. Most of them do great, but I have to say, and this is getting beyond medullary thyroid carcinoma patients. This is more of like, seeing patients with thyroid, all kinds of thyroid cancers over the years. I think there is a little bit of quality of life difference if you took 1,000 patients with lobectomy and 1,000 patients with total thyroidectomy, and you looked at quality of life of those patients, you'd probably see a little bit of difference in that the lobectomy patients are probably a little bit better in some way. And the way I would describe it is, for most patients, it may not matter, but there is a subset of patients, it may be like 20%, who, like, you take out their whole thyroid and they never feel the same. They just don't. Even if they're seeing an endocrinologist, they're trying to, they're managing their meds, and they're trying all different stuff. They try T3, they try all different kinds of stuff, and they just don't feel the same. And I don't have a good explanation for that. I don't think anybody does. The endocrinologist will try to work with patients and try different regimens of thyroid hormone, but it may be that there's just something that's a little different when you're taking hormone orally versus, for those patients, some different sensitivities versus getting it, naturally through your thyroid going directly into the bloodstream. I mean, we can't always recreate things exactly as God did. Even though the hormone is the same, it should work the same. But there's some patients who they just never feel exactly the same. They'll say, well, I've got, I feel a little bit more fatigued, or I've got brain fog, or and those things can be related to other things too. It's hard to pin it on the thyroid always. But I think some patients, they really feel like, yeah, ever since I had this thyroid removed, that's when this all started, and it's never been the same. And so, I believe them, and I just don't have an answer always for that. So.
Okay, thanks. The second question, can you get into the specifics that you consider when you're determining whether to do a lobectomy or the full total thyroidectomy? Like what are the numbers? What are the situations?
Yeah, I think the calcitonins are kind of, so the first principle, I mean, I mentioned would be is this germline disease hereditary or is this sporadic disease? So if it's germline, you're going to be a little bit less likely to do a lobectomy. You're probably going to be doing a total unless, unless you're operating on somebody, let's say you're operating on somebody who's got germline disease and it didn't manifest until they were like in their 70s or something. That's a very indolent germline disease in that patient. And you could entertain the option of like, if they just got it on one side and they want to treat it, you're like, yeah, I mean, they're probably going to be fine with a lobectomy. So you can make some sort of exceptions to that, even with germline disease. But in general, the first thing, is it germline? Is it sporadic? If it's sporadic, you're going to be much more likely to consider a lobectomy than germline. But then when you look at sporadic, it doesn't, it's more of, where the disease is locally, right? So if you do an ultrasound and a CT and you see everything is only on one side, only on the right side or only on the left side, you really don't have a good reason to take out the stuff on the other side. Not, I mean, depending on the situation. So, I mean, I think that's the first thing. If there's disease on both sides, whether it be in the thyroid or the nodes, then you're not gonna do a lobectomy. So, the first thing is, sporadic disease. The second thing is they've got to have a clean neck on that side. And then the third thing, you may take into account, some other, things like patient age, do they have distant disease or not? But, I think it's all, it's also, the patient, how they feel about it. I mean, I think you gotta listen to your patients and, if you have a patient who's like, look, this is a one and done surgery for me. I don't ever want to have another surgery for this. And, I'd rather just take the whole thing out. I don't want to worry about, having to go back and do something else in 5 years or 10 years. Even if it doesn't change my prognosis, I just don't want to have to do it again. I don't, I'm not as worried about the issues with lobectomy versus total in terms of quality of life. I'll accept that, but I just want the whole thing out. Then you listen to that. But if you have other patients are more like, no, like, look, I am concerned about taking my whole thyroid out. I'd rather keep my thyroid, keep my hormone, and then and realizing it probably doesn't affect their prognosis, then the only thing that's different is they may have to have another surgery down the road. Like if you've got a microscopic disease in a lymph node on that other side, and you don't go to the other side, it's possible that over time that will grow and it will, manifest, and then you got to do the other side. There is that possibility. So calcitonin CA numbers wouldn't change anything because again, I mean, that calcitonin CA numbers are more indicative of like, okay, does this patient have distant metastasis? Like if your calcitonin's 10,000, that there's some distant disease somewhere, even if you don't see it. There's plenty of patients who, they got calcitonin high, you don't see anything, but it's there. So, but again, it doesn't change. You take out half their thyroid, you take out their whole thyroid, your calcitonin, I mean, it may go, let's say you take out half the thyroid, the calcitonin drops from 10,000 to 8,000. Take out the whole thyroid, it drops from 10,000 to 8,000. It changes nothing in terms of that calcitonin. It changes nothing in terms of the distant metastatic picture. That disease that's distant is already there. It's not, and whether or not you need to start treatment is going to be based on how that disease behaves distantly over time. It's not going to be based on what's happening, locally. Even if something pops up 5 or 10 years down the road, a lymph node, and you got to go back and take it out, you're not going to have to start systemic therapy for that. It's going to be a surgical issue. So, I think calcitonin CEA is completely out the window. It doesn't really pertain to the conversation at all. The size of the tumor could, like if you've got like a 4-centimeter tumor versus a 1-centimeter tumor, yeah, I mean, is the 4-centimeter tumor going to be a little bit more likely to have a little metastasis on the other side that's microscopic? Yes. So you got to take that into account. I mean, it just, you take it to account in the patient discussion. I mean, it's like, is your risk, that would increase your risk that maybe there's a little lymph node that you got to take out later versus a 1-centimeter where you're not as worried about it. So it would make a little bit of difference in terms of the conversation. Yes.
Okay, we have a question from the virtual community. This is about staging. T1N1B or T2N1B, is that considered stage 4A?
T1N1B or T2N1B. Gosh, I got to look at that. So, N1B disease, I mean, I think it may be stage 3. That's something I need to look up. It could be stage 4, but practically speaking, I mean, I think it should be probably a stage 3. That's how I would think about it, but it could be technically a stage 4. That's something I'd have to. N1B means that there's lateral neck disease on either side. Again, I think I really would encourage people just to almost disregard the staging system for medullary thyroid cancer. I hate to say that, but I put almost no stock into it. I mean, because again, I think what matters is, what matters in medullary thyroid carcinoma in terms of your prognosis is, do you have distant disease? That's the first thing. Because if you don't have distant disease, then you're not really worried about much, right? You can take care of everything else. Then if you have distant disease, then the next level is, what's it doing? Is it just indolent and not doing anything, which is great? Or is it doing something? Is it growing? And the way you look at that is you look at that by imaging, you look at the calcitonin doubling time. And then, the next level is, if it is growing and if it is progressing, how does it respond to treatment? That's the next level. So if it's responding to treatment, great. If it's not responding to treatment, that's when you start to get into more trouble, right? So there's like multiple levels. First, you got to have distant disease. Then it has got to be progressing. And then it's got to be not responding to drug. When you have all three of those things, that's going to be a problem. So that's, I think that's where we get into trouble. But I think whether or not, you call a T2 N1B a stage 3 or a stage 4, or a T1 N1B a stage 3 or stage 4, I'd have to look up exactly, technically how we would classify that. But I think it matters not, would be, yeah. Radiation therapy. I don't know if any of you in here have had radiation therapy to your neck or elsewhere. Back of the neck. Yeah. Front of the neck. Yeah. Yeah. I think, what's done is done in terms of radiation therapy. I mean, it's so I don't mean to sort of state anything that makes you regret anything. But but I do think it's important to just understand in terms of our understanding of medullary thyroid carcinoma and the disease. It used to be that and this was a study that I show commonly. This was published in, I think, mid 2000s. It was before I was even, so this is 20 years ago, roughly. And it was before I was even faculty. I was like a resident at this time. So, and there was a lot more enthusiasm for radiation. And this was a study that was published from MD Anderson. And it was basically radiation is helpful in these situations for these patients. And it was really because, unfortunately, at that time, we didn't have any drug options, none. So basically, if you had somebody with really, with scary local disease, your only option to control things locally was surgery. And in terms of adjuvant therapy, it was you could do another surgery down the road, or you could use radiation. And radiation does have some benefit. I mean, it's not that it has zero benefit. Of course, if you have microscopic disease in your neck and you radiate it, it is going to lessen the chance that it comes back or lengthen the time until that disease comes back. No question. I mean, there is a benefit. The issue is that at what cost, and I think that's, radiation therapy, there's some acute effects, but there's also some long-term effects. So, not everybody has those, but there's, it certainly has significant effects on swallowing. Swallowing would be kind of the main issue, but also speech and other things. And you can get also, second primary tumors 20 years down the road from radiation. So it is something to be aware of. And now that we have other options, and also, we recognize that most patients who would have historically had an indication for radiation. So let's say you're back in 2005 and you're deciding to give a patient radiation, and it's going to be because they have pretty advanced disease in their neck. Well, those patients also are going to have distant disease, right? It goes together. You're not going to have a massive invasive tumor in your neck and not have distant disease. It just, those two things are pretty much, you hate to say always, but almost always going to go together. So the rationale is like, okay, you get all the disease out of the neck. You're worried, you could have some microscopic disease there, but you also have distant disease, whether it's microscopic or not. So you're not going to maximize your toxicity for the neck and give radiation. And then you've also got this other disease, you're thinking about like down the road, like what's going to be most threatening to the patient. It's not just what's in the neck, it's going to be what's in the rest of the body. And so if you've got a therapy that just treats the whole thing, you're going to kind of, and that's kind of in your back pocket, you're going to refrain from, maximizing that toxicity in your neck. So that's kind of the rationale and where we've come, I think, at MD Anderson, and I think elsewhere too, across the country. Although I still think that it's probably overused a little bit. I think the message has not probably gotten out, completely. Because this was in 2008, and this was all for postoperative radiation, presence of gross or microscopic residual disease, soft tissue extension, which that's a lot of medullary patients right there. Nodal disease, that's like 60% of medullary patients. Mediastinal involvement. So I mean, this is a lot of medullary thyroid based on these indications. But we've had new drug therapies. I don't need to tell you all about that. You're very well aware. 2011 is when kind of there were these FDA approvals. 2011, 2012. So that's when things started to change. We had more options. But even in the 2015 guidelines, still it was kind of really more liberal language in terms of microscopic or macroscopic residual MTC, extrathroat extension, extensive lymph node metastasis. I mean, certainly these are not current indications that we would use for radiation therapy. And I think there's been this general trend away from it, except in patients who have disease invasive of the esophagus or laryngotracheal complex. It's those two things. And even then, we don't usually use it. So I think this was published, I think, in the last 2 years. I can't remember if I showed this last year. I probably did. But it was published, I think, in 2024. This was our use of radiation therapy for the neck, right? So just remember, we're talking about radiation to the neck here. So when you talk about radiation to other areas of the body, it's a completely different conversation. And there's a whole nother group of things you have to consider. So this is not talking about radiation is very effective, for example, used for isolated, bone mets and also sometimes liver and lung mets too, in order to try to control a local area of disease that's not responding to systemic therapy, or maybe maybe you're trying to avoid having to start systemic therapy. So you're trying to play this kind of whack-a-mole game with the distant disease in order to delay the start of the systemic therapy. So you can use it. This is talking about radiation for the neck, and you can see this, general trend. And then in 2018 and 2019, the study only went up to that far. There were 0 patients who got it. So, and I think that trend has continued. It's almost never that we would use it. So, even in patients who got really bulky disease in their neck, as you would see from these CT scans, this is, before surgery here, you see the disease down in the mediastinum. We would not recommend radiation therapy for any of these patients. You see this patient has a lot of lymph node disease scattered throughout the neck and mediastinum. And, again, the calcitonin's 19,000. So, we're going to take all this out. Could there be microscopic disease in the neck? Of course, but the calcitonin's not going to go to 0 with the surgery. They're still going to have probably some small disease in the liver, lung, bones. And so we just watch that over time, and we treat what comes up over time rather than sort of using that hammer of radiation therapy up front. So any questions right now? I think I've got a few more slides, and then we can take a quick break if we want to. So this is, I'm not going to spend much time. You all know this. About 60% of medullaries have a RET mutation. And then the second most common mutation is a RAS. I know that there's at least 1 or 2 of you here because I've talked to you who have a RAS mutation. And so KRAS and HRAS. And then, about 30% have no RET or RAS mutation. And so I think that there's been some other talks in terms of looking at that. I think Libby Grubbs may have given a talk yesterday in terms of looking at some various mutations. And so we won't go into detail about that. I think the traditional drugs that have been used, cabozantinib, vandetanib, those are very good drugs. You know, we don't ever want to say that they're not. And many of our medullary thyroid carcinoma patients are on those drugs and can work very well. But you know, I think we have to be honest that does have a little bit of toxicity. So you know, this is looking at progression-free survival of patients who were using the drug versus placebo. I mean, clearly the drug has a good benefit here. The difference between these curves, and this is an older study from 2013, but it's got side effects, right? Treatment-related adverse events for cabozantinib. 80% of cabozantinib patients in this study had dose reductions. That means they had side effects and had to reduce their dose because they were having side effects. 15% had to completely stop the drug because it was having too much side effects. So we got to be real about that. It's a real thing with cabozantinib. It works, but in similar, we could show similar data for vandetanib. These drugs, vandetanib, cabozantinib, kind of target a lot of different things, and that's why, you know, their side effect profile is a little bit more because it's more of a shotgun approach in terms of what it's targeting. You know, it targets a little bit of red, VEGF, and some other things as well. And VEGF receptor being one of the main targets here. So, you know, we do have you all are obviously at nauseum aware of the new RET-specific inhibitors, selpercatinib and pralsetinib. These are, you know, these were approved in roughly, 2020. Of course, the pralsetinib is no longer approved for medullary, but we still have the selpercatinib, and we still can get the pralsetinib for some patients as well. And, you know, just showing, you know, this data, these drugs work very well. You get some nice deep responses, 60-70% responses in patients who have RET mutations, but it's not, you know, it's not every single patient. You see, there's a whole spectrum, you know. I mean, each of these lines is one patient. You know, so most of our patients are having really good responses over here, but I mean, there's some patients who don't, and you know, so we're still trying to figure that out. There's some patients who, you know, have less than 30% response even over here, you know, maybe about 10% of patients. So that is something that we're aware of. And this is for patients who had progressed on cabozantinib or vandetanib, and they still can have a good response to the RET-specific inhibitors. And we see a massive decline in the tumor markers, you know, with these drugs. Calcitonin, you know, often goes close to zero, you know, 90, 95, even 100% response of the calcitonin. Now, if you restart the drugs, that calcitonin is going to start coming back up, you know. So that's the thing. You know, when you talk about systemic therapy, I think there's often a sense of not understanding cancer in general, not understanding medullary cancer. You know, patients will often come in and they'll say, you know, well, look, you know, I've had surgery, my calcitonin is still, you know, 1,000 or 5,000 or whatever it may be. You know, I want to treat this. You know, we need to start treating this now, you know. And, you know, you do a scan, they don't have anything that you can see anywhere in their body, but you know that they've got some microscopic disease there because their calcitonin is still elevated, right? So it's 1,000 or 5,000. And we showed that figure earlier. When it's over 500, you start to worry, yeah, there's probably some distant disease there. You know, that's when you start seeing it, definitely over 1,000. So, you know, it's there, and they're like, you know, it's there. Why aren't we treating this? And well, it's because these drugs aren't curative. Yeah, we don't have unfortunately, we don't have a curative drug. And so, you know, once you start it, you're kind of on it indefinitely. You don't really have a good off ramp for it. And so, and that's okay. It's better to have the drug than not to have the drug. I mean, gosh, we're so grateful that we have the drug now and we can use it and for all of our drugs. But I mean, there is a sense that, like, you know, if you can get by for, you know, a year, 5 years, 10 years without treatment, we'll take it. And because we know that, you know, there's a long runway of disease progression in the lungs, in the bones, in the liver before a patient's going to become symptomatic, right? We can see it. We can see it when it's, less than a centimeter even, but certainly when it gets over a centimeter, we can start to see the disease on the imaging, and it's not going to be symptomatic at that point. So we have a long runway to be able to treat patients when that disease is a centimeter, and growing before. So if you don't have anything that we can see, certainly we're not going to treat it. And even if you do have something we can see, often we're going to wait to see, because when you present as a new patient for the first time, as you've all experienced, we don't know how fast this disease is growing. I mean, it could be a fast grower or it could be a slow grower. And medullary thyroid carcinoma, in terms of growth rate of distant disease, is very variable. It is not a one size fits all. And so, you've got some slow growers and some medium growers and some fast growers and everywhere in between. And so you kind of need to see what that disease is going to do and what flavor of disease that is before you start treatment, because you don't want to be starting treatment on somebody that may not need it for 10 years. And so, okay, so there we have a few questions.
What about the case where you give treatment so that you can reduce that burden to do surgery?
Yeah.
Are they on it indefinitely? I think we asked
No,
Dr. Wu this yesterday.
yeah,
like,
that's an exception.
what if the exception is like they've been on it for a year to
Mhm.
get that burden down though?
Yeah, no, you would be able to come off of it after surgery. I'll present that study in the next session, that neoadjuvant study where it's the first neoadjuvant study that's been done. It was multi-center. We enrolled 30 patients. We just presented it 2 weeks ago at ATA, American Thyroid Association meeting. We can talk about that study in the next session, but basically, no, that's a unique case. You're using it for a specific purpose, is to shrink the local disease to make the surgery easier and less morbid. And then you come off of it, and then you're off of it for indefinitely. You would only need to go back on it if you have a reason, and that's usually going to be because you've got progressive distant disease. So that's kind of how that works.
What is the incidence of MTC and why are we seeing this disease? Is it better screening, patient self-discovery? Are there contributing factors?
I don't think that there's any true increase in medullary thyroid carcinoma. I don't think that there's really any studies. Well, there's always going to be some study somewhere which suggests something like that, but I don't think the vast majority of studies and experts would say that medullary thyroid carcinoma is increasing in incidence. I don't think that at all. I don't think we have any reason to believe that. In terms of, if there is a little bit of uptick in prevalence or incidence or prevalence, it is because of improved detection. I mean, there's all kinds of these genetic studies now. I mean, where patients are getting genetic screening. What is that, 22andMe or whatever that one is, and everything in between. Like you can 20andMe, 23andMe, yeah, 23andMe. Sorry, there's 23 chromosomes. So yeah. Most of us have 23 chromosomes, so that's right. So 23andMe and I have no stock in 23andMe. I've never done the test myself, but yeah, so there's these companies out there that you can go as a patient, you can do you pick up some rep mutations that way, or you're at a cancer center and you have another cancer and they happen to do a genetic profile on you, and it's like, oh, by the way, this patient has a rep mutation. So you pick up all these incidental rep mutations, and a lot of this disease would have been indolent. Like you could have had that patient go through their whole life and never discover it, but you're discovering a lot more of it incidentally. And there's some of these mutations, for example, like the 804 mutation is one of them that's like really increased in incidence, but a lot of those are indolent disease. And so, I think that may have been spoken about in another lecture, but some of these more indolent mutations that are picked up on screening, are not necessarily going to be life-threatening ever to the patient. Now, you don't know that, and so it is still scary for the patient, and you still have to, make decisions about treatment and stuff like that. But I think if there's any increase in incidence, it's going to be because of things like that. and also, increasing ultrasounds and increasing screening with ultrasound. Everybody at their work has, or church, or has a screening. So I think that, leads to an increase in diagnosis, and diagnosing some of the indolent cancers that would have never been diagnosed, 20 or 30 years ago. That person would have, lived and died with their cancer and never known it. And there are some of those. I know that that's probably not the norm in this group, right? In this group, it tends to be, probably more of the less indolent medullary thyroid carcinomas, but there are some of those out there, indolent medullary thyroid carcinomas that just don't manifest until really late in life if they're germline, and those are not particularly usually going to be life-threatening. I saw a mother and daughter not that long ago, and the mother, is just finding out about, her medullary thyroid carcinoma at age 60, and the daughter's in her 30s, and so I'm going to end up operating on both of them, but the point is that for the 60-year-old, I told her, I said, look, I mean, we could observe this, because this, you may not ever need treatment for this. It may not shorten your lifespan, because it's taken that long. She's germline. It's taken that long for the disease to manifest, and it's not real advanced. So it may be something that you could not need to treat. But most patients, psychologically, that's a hard thing to do, and they kind of want it out, but that is an option. So I think maybe I answered too much there, but yeah.
And are there any known environmental causes, like ground, environmental, radiation,
No.
food, medication?
None.
Okay.
No. Yeah, I mean, if there were, you'd be hearing all about it. I mean, we'd be talking about it. We'd be like, it'd be on the first slide of every I mean, you would know, all right? It's not going to be in some dark corner of the internet somewhere where it's like, some doctors claiming that they figured this out, and it's, everybody, I mean, that's just not the way science works. And it's honestly not a big conspiracy theory either. I mean, it's just, it'd be hard to pull off a global conspiracy about not, recognizing that, there's something that causes this. I mean, because hopefully, there are a lot of doctors who are good people, and they'd be like, no, that's not right. So, I mean, I think, that there is nothing that we're aware of that increases your risk for it. Except having the RET mutation, obviously. I mean, that's clearly well recognized. But other than that, there's nothing that's really we can say that would increase your risk for it, or that you should do differently, that you have it. Yeah, I mean, anyway, we can talk about more later. But
Okay,
yeah.
I got a couple more questions. Do you have any suggestions for alternative biomarkers to use for monitoring MTC recurrence and progression? I have negative calcitonin, MTC, pathology reviewed at U of M. Even with a 2.6 centimeter tumor, I was negative for serum calcitonin and CEA. My tumor did not stain positive for calcitonin, so we are assuming that it did not secrete it.
Yeah, I mean, that's an unusual situation, but you do have some medullary thyroid cancers which are not good calcitonin producers. There is not another, I mean, we are studying some cell-free DNA, circulating tumor DNA, things like that. It doesn't work really well for medullary unless you've got a lot of disease. Then you can pick it up, but it doesn't work very well because when you're doing cell-free DNA, circulating tumor DNA, I mean, obviously the tumor's got to be in the bloodstream to pick it up. So we are looking at that for some applications where patients have really advanced disease, and you can pick it up that way, but not anything else and not anything that could be used for the vast majority of patients.
Yeah. And this person's in a rural area, and they're having problems figuring out how they're going to monitor her cancer.
Yeah. Well, I mean, you would if it's truly a non-calcitonin producing medullary, like you had the tumor, it wasn't producing any calcitonin. Yeah, I mean, I would want to get some imaging. I want to get some baseline, CT chest, some liver imaging, and some spine imaging, like an MRI of the spine, a dedicated liver MRI, just to make sure you don't see anything there. That's basically the distant workup for medullary thyroid cancer that, is done. But yeah, if you can't rely on calcitonin, which is rare, but it does happen occasionally, rarely, you're going to need to probably get some baseline imaging to make
Yeah.
sure that you don't see anything. And then you would just have to decide, how often you're going to follow that imaging. If you don't see anything there, maybe you just do it yearly.
I think the problem with this person is they're in a rural area. Their insurance won't cover them a trip to MD Anderson or a center of excellence.
Well, in the guidelines, you can look this up, or we can. There's very clear, what the workup for and in the new guidelines, there's going to be a whole table on this. What the workup for imaging workup for medullary thyroid cancer is, but you basically just want to get a good look at the lungs, liver, and bones, and so you're going to get a CT of the chest. You're going to want to get a CT or an MRI that's basically protocoled for the liver, and you're going to want to get a MRI of the spine. Those three things should cover it in terms of distant disease. And then you also, obviously, you need to keep an eye on your neck. So you need to be doing a CT neck and an ultrasound of your neck. Ultrasound is a little bit subjective in terms of who's doing it. Not everybody has the same expertise. And so CT would probably be good if you're in a rural area, because I just don't know what the quality of the ultrasound is. But so CT neck, chest, CT or MRI of the liver with liver protocol, and an MRI of the spine would be what you would want.
Okay. Is there a major prognostic factor within having angio invasion versus lymphatic invasion as a post-surgery finding, as far as how this may spread or behave, et cetera? Are there any predictive factors?
Yeah, angio invasion is one amongst many predictive factors. I don't think it's enough. It's kind of an interesting thing to academically, or, but does it really change that particular patient's treatment? No. It kind of, yeah, it may tell you a little bit. Of course, you would rather let me just say, lymphatic invasion is kind of don't really worry about it. It's, most patients are probably going to have lymphatic invasion. Angio invasion, yeah, if you see that, true angio invasion means that, and this is not only for medullary, this is for other thyroid cancers as well, that you're going to have risk that tumor has, because angio invasion means that the tumor's going into the blood vessels. That means that it's likely that there's some tumor circulating in your bloodstream, which means that it's more likely that you're going to have distant metastases. So angio invasion is a risk factor for distant metastases, but it's not going to change anything in terms of your treatment. You're basically still going to have to do the same thing, which is, what's your calcitonin CEA? How is that changing over time? And more importantly, how is your imaging changing over time? That's not going to direct any treatment.
Okay, so the next question was about monitoring, and I think you've covered that. And is the monitoring that you suggested any different for hereditary versus sporadic?
No, there's no difference in monitoring in general between hereditary and sporadic, except with hereditary, if it's MEN2A, you're kind of keeping an eye on, the parathyroid glands, and, if it's MEN, and also pheochromocytoma. So you're kind of understanding that, there's other things that can be associated with MEN2A and 2B that are not thyroid cancer, parathyroids, adrenal pheochromocytoma. So you're kind of aware of that, but in terms of the medullary thyroid carcinoma, there's no difference.
Okay. Somebody asked if there's any sort of vaccine.
No vaccine. No, sorry. Yeah. That would be incredible.
Can a patient with sporadic MTC going on 20 years with no known RET mutation and surgery in the very near future take drugs and treatment for regression of disease to help with the surgical outcome?
Yes, it's possible. But it really depends on
Add calcitonin 312, CEA 30.1.
Yeah, the calcitonin and CEA are kind of irrelevant to the conversation. When you're talking about using drug in order to, before surgery, I think that's the question. Do you need to use drug before surgery? It's really not a question of what the calcitonin and CEA are. It doesn't matter. It could be 1,000, it could be 10,000, it could be 100,000. It doesn't matter what it is. It's not going to affect your decision. It's mostly about what the disease looks like and how morbid you think the surgery is going to be. And if you think that by shrinking that disease, by 30, 40, 50%, it would facilitate the surgery. Sometimes, we know that we can shrink the disease 30 or 40 or 50%, but it doesn't matter because it's not going to change what we need to do with the surgery. So, examples are if you've got a 4 centimeter tumor in the thyroid or a 4 centimeter lymph node in the neck, and it's not really invading anything, then the size doesn't really matter in that case. It's not invasive of anything. We're still going to get it out the same way. If it shrinks down to 3 centimeters or 2.5 centimeters, whatever, it's still exactly the same surgery. So I think the key is it's usually, in order to make a difference in surgery, it's got to be, the disease has to be invasive of something important. And the surgeon has to believe that by shrinking that disease 30%, 40%, whatever it is, that it's going to make it, somehow the surgery better, or, less likely to have to sacrifice something like the recurrent nerve. So I think that's kind of where the conversation would need to go. When you're dealing with recurrent disease, so, as opposed to just primary disease, it is a little bit different in terms of whether, your thought process in terms of using the drug before surgery. It's a little bit, I would say it's a little bit harder to get the benefit in a recurrent setting than in a primary setting. And there's a lot of reasons for that. But I think that is another thing to look at. I mean, most of the patients where it's more of a straightforward decision for using drug before surgery are going to be patients with primary disease. I'm not saying that there aren't recurrent patients that we use it. We do, but it's a much more nuanced conversation because, if you've got, well, we'll leave it at that for now, and then we can discuss more if there's any other.
I have never had a CEA higher than 8, but a calcitonin 40,000.
Yeah.
So what's that about? And
Well,
74?
yeah, I mean, that's a good question. It's something that we theorize a lot about. But we don't have a lot of good answers, and it's not a one size fits all. So in general, for most people, obviously not you, but for most people, the calcitonin and CEA tend to kind of move in tandem. The higher the calcitonin, the higher the CEA. That's kind of generally a general principle, but it's not always. There's some tumors that, for whatever reason, they produce more calcitonin, or there's some tumors that produce more CEA. And it's, I would say this is a very soft, very, very soft sort of observation. It's not something I would put a lot of emphasis on. But I think that the tumors that are more calcitonin driven and less CEA driven, not always. So if somebody comes in after this lecture and says, look, I have a calcitonin of 100,000 and a CEA of 2, and I've got a really aggressive tumor, I'm going to say, yes, that I understand. But in general, if you've got a higher calcitonin and a lower CEA, there's probably something in a lot of patients, it's a little bit more favorable about that than the other way around. If you got a really high CEA and a lower calcitonin, there may be something unfavorable about that tumor, but it's not, again, that's not a one size fits all comment. But other than that, again, I don't think it changes how you're going to be treated, which is generally, when you have structural progression of disease, meaning when the imaging shows that the tumors are growing is usually when you need to treat it. It's not usually based on any specific number of calcitonin or CEA, just to be clear.